on these. Right. A lot of questions are going to be on the pronephros, the metanephros, and the mesonephros, right? These things are going to form a lot of important structures later on, right? So the first kidney, the first excretory structure, right? So for example, the USMLEs and U World or NBMEs could give you a question. They could say that at 25, that a scientist is experimenting on a human fetus, right? So an experiment scientist is experimenting on a human fetus, or the scientist takes some embryonic cell and the scientist starts to grow that embryonic cell into a culture, right? And whenever the scientist starts growing that, the scientist sees that the embryonic cell is now excreting some kind of things right from it, and they are going to ask you what is the most likely structure which is secreting these things, right? So the most likely structure is going to be the pronephros, right? So the pronephros is the first excretory system of the body, right? Now the important thing regarding the pronephros is that it's going to form during the fourth week of development, right? The second thing is that it's going to form during the fourth week of development. Now this is the thing that is going to degenerate, right? So there is no going to be no so no so no remnant is going to be left behind of the pronephros, right? So no remnant of the pronephros is going to be left behind. All of the pronephros is going to get degenerated. It's going to go away, right? All of it is going to go away and nothing is going to left behind, right? And after the pronephros gets degenerated, the next thing that we are going to get is the mesonephros, right? Why is this mesonephros important? This mesonephros is important because it's going to function as the kidney as well, right? So for first thing is that it's going to function as the kidney, right? The second thing is that this mesonephric system is going to form the genital system in the future as well, right? So the mesonephros side. So again, they could give you a question. They could ask you that a scientist is doing an experiment, right, or someone is doing an experiment on a patient, right, and they come across a structure. So they come across a rudimentary structure, right, which is known as the mesonephros, right, or a structure that is arising during the fourth week of embryonic development, right? So during the fourth week of embryonic development, a structure is gonna come, right, which is known as the mesonephros, and then they're gonna ask you what is this structure gonna form, right? What is this structure gonna form? So first of all, this structure is gonna act as the interim kidney, right? And after that, in the males, right? In the males, it's gonna cause the formation of male genital system, right? In the male, it's gonna lead to the formation of male genital systems, but in female, it's gonna get degenerated, right? In female, it gets degenerated. Why does it get degenerated? It gets degenerated because may in the males, right? So in the males, it's gonna form. In the females, it's gonna get degenerated because this is gonna need anti-Mullerian hormone as well as the testosterone to remain potent, right? So Mesonephros is gonna need anti-Mullerian hormone and the testosterone. We are gonna go into the detail of the formation of the male genital system later on, but keep this thing in mind, right? That the mesonephric system is gonna form the male duct system in the male genital system. Okay. Now there are two ends of the Mesonephros, right? So this thing is not written in the first aid, but this thing is very important. So we have two ends of the Mesonephros. What are those two ends? So one end is known as the cranial end. So one end of the mesonephros is going to be the cranial end, right? And the other end is going to be known as the caudal end. Why is the cranial end important? The cranial end is important because it's going to form the Bowman's capsule, right? In the adult life, it's going to be the remnant of the Bowman's capsule. Whereas the caudal end is going to lead to the formation of male genital system, right? And specifically, it's going to give rise to mesonephric duct, and mesonephric duct is then going to form ductus deferens and seminal vesicles and ejaculatory duct, right? Now they could ask you the embryonic origin of the seminal vesicles or the ductus deferens of the ejaculatory duct, right? They could ask you the embryonic origin of any of these things, and you are going to know that the embryonic origin of these things come from the mesonephric duct, right? And again, I'm going to ask you, what is the most likely fate of the mesonephric duct in females? In females, the mesonephric duct is going to get degenerated, right? Now, the caudal end of mesonephric duct is also known as the Wolffian duct. It's also known as the Wolffian duct. Now we have the third most important kidney, which is going to be the permanent kidney, which is known as the metanephros, right? Now again, this kidney is going to come during the fifth week of development, right? And when is the development be gonna completed? The development is gonna be completed at 36 weeks. Now we have two kinds of we have two parts of metanephros, right? And both of these parts are very important, right? Keep these parts in mind. So these are gonna form the parts of adult kidneys as well. And I'm gonna tell you how the UWorld frames questions, how the NBME frame questions on the metanephros specifically, right? So there are gonna be two parts, right? So the first part is gonna be ureteric bud. So what is the ureteric bud? The ureteric bud is a structure, right? So which is also known as the metanephric diverticulum. So let me show you. Let me first write it for you, and then I'm gonna show a very good picture of this thing. Right. So basically, we have a normal urogenital sinus, right? This is gonna be a urogenital sinus. From this, a bud is gonna form out, right? A bud is gonna form out here. The bud is gonna form out here on the right side as well, right? This bud is known as the ureteric bud, right? Again, this bud is known as the ureteric bud. This bud, this structure, this bluish structure, dark blue structure, or the greenish structure is known as the ureteric bud, right? This thing is known as the ureteric bud, and the rest of the part, this part, the pinkish part, is known as the metanephric mesenchyme, right, or metanephric blastema, right? What is the difference between both of these, right? So both of these are gonna interact with each other, right? Both of these are gonna be interacting with each other, and the duct is gonna form the duct system of the adult kidneys, right? So they are gonna form the ureters, right? So they are gonna form the ureters. They are gonna form the pelvis, ureteric pelvis as well, right? They are gonna form ureteric calyx as well, right? So renal calyx is gonna be formed from here, and collecting ducts are gonna be formed from here as well, right? Now, how is this thing important, right? So remember, when we were discussing SIADH, right? When we were discussing SIADH, how does the ADH hormones work, right? So we knew that the ADH hormone is going to act on the collecting ducts, right? The ADH hormone is going to act on the collecting ducts. So now they could integrate the question in this way. The USMLEs could give you a question that a 45-year-old male comes to you. That male is having a lot of secretion of ADH, right? Due to that secretion, that patient is having hyponatremia, right? And that patient had a head trauma as well, right? And then they could ask you, the hormone which is elevated in this person is going to act on which of the following is going to be derived, is going to act on the structures which is derived from which of the following, right? And then one option could be of pronephros, the other options could be of mesonephros, and the third option could be of metanephric mesenchyme, but it's going to come from the ureteric bud, right? Because the ureteric bud is going to form the collecting duct, and on the collecting duct, right, the ADH hormone is going to act, right? So that is why these things are important, right? These things are going to be formed in these ways, right? Now the other thing is that where does the ureteric bud comes from, right? So the ureteric duct is going to come from the mesonephric duct, right? So the mesonephric duct, which was the second kidney, is going to form the mesonephric duct, right? And then this ureteric bud is going to give rise to all of the other parts of the kidneys. What are those parts? So the proximal convoluted tubule, the loop of Henle, as well as the distal convoluted tubule, all of these are going to come from the met- metanephric duct, metanephric blastema, right? Now, how does this metanephric blastema gets important, right? Why is this metanephric blastema important? This metanephric blastema is important because whenever we are going to have a problem of the kidney, whenever we are going to have any congenital problem such as renal agenesis in which the kidney is going to be absent, right? If we are going to have cystic diseases of the kidney, right? If we are going to have horseshoe kidneys, so we are going to cover all of these in details. Then in all of these conditions we are going to have a problem between in the metanephric blastema, right? So any questions till now, guys? If not, we are going to move forward, and then we are going to go into the clinical details of these things.
So
Okay.
the ureteric bud is actually the derivative of mesonephric duct,
Yes,
or the
exactly.
and it is given under the heading of metanephric diverticulum. So, but it is
Yes,
basically derived from mesonephric. It is.
yes. So let me summarize and let me make sense. So basically, during the fourth week, right? So during the fourth week, we are going to have mesonephros, right? And I told you how many parts of Mesonephros do we have? What were the two parts of Mesonephros?
Two
Anyone?
parts.
Yes.
Cranial and
Yes.
caudal.
So the cranial and the caudal part, right? So the caudal part was also known as the mesonephric duct, right? So the caudal part was known as the mesonephric duct, right? So this caudal part is then gonna form into two things. It's gonna form the ureteric bud, right? Which is also known as the metanephric diverticulum. Why is this known as the metanephric diverticulum, right? Because this is gonna, so if this is the metanephros, if this is a small metanephros, it's gonna form a pouching from this, right? That is why this is known as the metanephric diverticulum, right? Now this mesonephric duct is gonna form the ureteric bud, and it's also gonna form the male genital system, right? And then this ureteric bud is gonna lead to the formation of metanephric blastema, right? Or metanephric mesenchyme. So this is how it's gonna work. Now, they could ask you the structures of the kidney, right? So they could ask you any structure of the kidney, where do these things come from, right? So, for example, let me make a table for you, right? So first of all, if they ask you where does the Bowman's capsule come from, right? So the Bowman's capsule is gonna come from the prone, cranial end of Mesonephros, right? Okay, so it's gonna come from the cranial Mesonephros, and then the collecting system is gonna come from, it's gonna come from the ureteric bud, right? And then the proximal and the distal convoluted tubules. So the PCTs and DCTs are going to come from the blastema, right? So basically, thiazide diuretics. So remember, thiazide diuretics are going to act on the distal convoluted tubule, right? And on the proximal convoluted tubule, SGLT2 inhibitors are going to act, right? So what are SGLT2 inhibitors? SGLT2 inhibitors are given to the patient of diabetes, right? They are given to the patient of diabetes to block the absorption of glucose, right? They are going to block the absorption of glucose. They are going to improve the cardiovascular outcomes. So again, they could give you a question that scientists have successfully developed a drug that is treating diabetes and that is reducing the cardiovascular mortality outcomes in diabetes, right? This drug has a side effect of causing UTIs and candiduria or candidiasis and all of those symptoms, right? So these are this drug has a side effect of that. Now they're going to ask you what is the most likely mechanism of this drug, right? And they could give you a very convoluted option because now the US UWorld and USMLEs, right? They know that all of you have read the first one, right? But they want you to integrate these things together, right? They want you to integrate these things together, right? So I want you guys to know that whenever you are thinking of proximal convoluted tubule, immediately the next thing that should come into your mind is that, so if I say proximal convoluted tubule, what things should come into your mind? So what things uh, what are the things that come into my mind? So the first thing that comes into my mind is SGLT2 is going to have work here, right? Acetazolamide is going to work here, right? So these are the integrations, these are the memory integrations that you're going to make, right? So these takes time, but if you have a good mentor, right, if you are following someone, these things are going to be easy, right? So SGLT2 comes into my mind, acetazolamide comes into my mind, right? At the same time, then the metanephric mesenchyme is going to come into my mind as well, because it's going to be derived from the metanephric mesenchyme, right? So these are all of the things that are gonna come into my mind whenever I hear the word proximal convoluted tubule, right? Whenever I hear the word proximal convoluted tubule, all of these things are gonna come into my mind, and they are gonna form a very important linkage, right? They are gonna form a very important linkage because in the other stages, right? Whenever you go forward, you're gonna see USMLEs are not just about memorizations; they are about integrations. They wanna check all of the integrations that you're forming, right? So this is the first thing. Now the next thing that is important is that between the ureteric bud, right? So the point where the ureter meets the, so this is an important thing. The points where the ureter meets the renal pelvis, right? So let me show you a diagram if we have one, right? So Okay, so this is the ureter, this is the ureter, and this is the renal pelvis, right? Where these two things meet, where the renal pelvis and ureter meets together, this point is known as the ureteropelvic junction, and this point is known as the ureteropelvic junction. And why is this point important? This point is the last point in the renal system that is going to be canalized, right? This is the last point where it's going to be canalized, right? And this is the most common site of urinary tract obstruction, right? This is the most common form of congenital obstruction of the urinary tract, right? Now, what is going to happen? How is the patient? Now we are going to do a thing which is known as the Porter sequence, right? We are going to do a very important topic in you step one. This is very high yield, which is known as the Porter sequence. Now we are going to focus on Porter sequence, and that is linked to the ureteropelvic junction. So what is Porter sequence? So in order to understand Porter sequence, we have to go through a whole lot of physiology, right? So I want you guys to remember this physiology in a good way because this is going to help you a lot. So remember, whenever a fetus is in the mother, whenever the fetus is being carried by the mother, the fetus is being surrounded by amnion and a lot of layers, right? The fetus is being surrounded by a lot of layers, right? And these lot of layers, all of these layers that are surrounding the fetus, they need fluid, right? And that fluid is known as the amniotic fluid, right? Now, where do we get the amniotic fluid from? We get the amniotic fluid from urination, right? The amniotic fluid is gonna come from urination. So the amniotic fluid is derived by urination. Now, if a patient cannot urinate properly, right, the amniotic fluid is going to decrease, and that thing is known as oligohydramnios, right? Again, I'm telling you that if a fetus cannot urinate properly, if a patient cannot urinate properly, that patient, that fetus is having problems urinating properly, there is going to be less amniotic fluid, and that thing is going to be known as oligohydramnios. So if this is a membrane, and inside the membrane, if this is a fetus, right? So if this is the fetus that is present inside the membrane, what is going to happen is that when the fluid is going to be restricted, right, the the membrane is going to attach with the fetus, right? When the membrane is going to be attached with the fetus is going to get compressed, right? And when the fetus is going to get compressed, the limbs are going to get deformed, right? You're going to get limb deformities, you're going to get facial deformities, your chest is going to be flattened. And when the chest is going to be flattened, right, the lungs won't develop. The lungs won't develop, and then there would be pulmonary hyperplasia, right? Now they could give you a question that they could. So now, first of all, let's look at the causes, right? So how does this thing happen? So for example, if the kidneys are not functioning properly, right? So how can the kidneys not function properly? The first most common thing is that if a fetus is having ureteropelvic junction obstruction, so if this area is blocked, if this area is blocked, if this area is not canalized, the patient is going to get ureteropelvic junction obstruction, right? A lot of urine is going to fill up here, which is known as hydronephrosis, and then the patient is going to have a lot of fluid in the kidney, and no fluid is going to get urinated. So the patient is then going to get Potter sequence, right? There is going to be oligohydramnios, there is going to be Potter sequence, right? This is the first way it can lead to that. The second way is that the patient may not have any kidneys, right? So there is going to be bilateral renal agenesis, so both of the kidneys are going to be absent, right? Now, the third thing is that if the mother is using ACE inhibitors, right, this is a very important cause. So, ACE inhibitors are contraindicated in pregnancy, right? And I have already told you guys that in pregnancy, we give the patients only three antihypertensives, right? The first one is nifedipine, the second one is labetalol, the third one is hydralazine, right? If if the blood pressure is not being controlled with these three ones, then we can give the fourth one, which is known as the methyl dopamine, right? So these four are the main ones. First of all, you give the patient nifedipine, labetalol, or hydralazine. After that, you are gonna move the patients to methyldopa. You do not give the patient ACE inhibitors. Why? Because the ACE inhibitors slow the function of kidney. They are gonna reduce the blood flow that is gonna come to the kidney, and then there is gonna be Potter sequence in the patient. Right. At the same time, if the mother is not having enough blood supply coming to the fetus, right? Then not enough blood is gonna go to the kidneys, and the patient is gonna have Potter sequence as well. Right. Now there is a mnemonic for the Potter sequence, which is known as the POTTER, right? So P stands for pulmonary hyperplasia, O stands for oligohydramnios, which is gonna cause it. T stands for twisted face. T stands for twisted skin. E stands for extremity defects, and R stands for renal failure. Right. The babies who cannot teeth, they are gonna get Potter sequence. They are gonna give you a characteristic baby. So they are gonna say that a baby comes to you and that baby is having limb deformities. The baby's limb is having club feet, right? The feet are not straight and the feet are inverted or the feet are reverted, and the ears are low set. There is the nose is flattened, right? The chin is very much visible, right? The jaw is visible, the maxilla is visible, right? And the patient cannot breathe properly. The baby cannot breathe properly, right? And then they're going to ask you what would be the most likely cause of this condition, right? So the most likely cause of this condition would be oligohydramnios in the patient, right? It would be oligohydramnios in the patient, right? And then what is the most common cause of prenatal hydronephrosis, or most common cause of obstruction of the urinary system? Then that is gonna be uretero-pelvic junction obstruction, right? So any questions still here? Okay, what do you want me to explain again? Sure. Okay, okay. Uh, so so basically, I told you that. Okay, so normally this is a baby, right? And this baby is having fluid around all of the baby is gonna have a lot of fluid around it, right? So now this is a normal baby. So basically this is polyhydramnios, but you get the concept, right? So look at this baby, right? There is a lot of fluid that is present here. So how where is this fluid coming from? This fluid is coming from the kidneys, right? The baby is forming fluid, the baby is urinating in this pouch, and a lot of fluid is being formed, right? A lot of fluid is being formed and the baby is urinating this fluid, and as a result you are getting this amniotic fluid. Now if I say that the patient is having any problem, such as the patient is having ureteropelvic junction obstruction, so the ureters cannot get any urine. So when the ureters cannot get any urine won't go out of the baby, and then there won't be any fluid here. So when no fluid will be present here, it is gonna get compressed, the baby is gonna get compressed, the limbs are gonna get compressed, the face is, you can see easily how the limbs and the face are going to get compressed, right? The chest is going to get compressed, there won't be any chest development, there would be limb deformities, there would be facial deformities, all of these things are going to be present, right? Now there are a lot of causes of the renal failure in the babies, right? So it may be due to ureteropelvic junction obstruction, right? It may be due to autosomal recessive polycystic kidney disease that we are going to discuss in detail later on in the pathology portion of this bootcamp, right? Or it may be due to ACE inhibitors. So whenever a mother is taking ACE inhibitors, that is going to reduce the blood that is coming to kidneys. And when no blood comes to the kidneys, no urine is going to form. So remember this thing. This is very important. This is a very important concept. When no blood is coming to the kidney, nothing is going to be formed, right? Again, if no blood is coming to the kidneys, nothing is going to be formed. Okay, no urine is going to be formed. So this is an important thing. Okay, and this is how the patient is going to present, right? Now I want to ask you once again, right? So whenever you think of glomerulus, proximal convoluted tubule, loop of Henle, distal convoluted tubule, the first thing that should come into your mind is these are going to get derived from metanephroblastema, right? If collecting duct comes through you, its ureter comes to you, renal pelvis come to you, if calyces come to you, ureteric butt should come into your mind. If ejaculatory ductus deferens or any male systems comes to you, then it's gonna be derived from mesonephros, right? If they ask you about pronephros, it's gonna get degenerated. Okay. Now, if they ask you about any renal pathology and they ask you the cause of that, then the cause of that would be abnormal interaction between the ureteric bud and the metanephric blastema, right? So the ureteric blood and the metanephric blastema, right? So this is the ureteric blood, and so this is the ureteric bud. This is the metanephric blastema. They are not going to communicate with each other, and that is going to lead to the formation of kidney problems. Okay. Now we are going to move into a very important topic, which is known as the horseshoe shaped kidneys, right? So we are going to move to another topic, which is known as the horseshoe kidney. Okay. So what is a horseshoe kidney? So one other thing that we need to remember during the kidney development is that whenever the kidneys are being formed, they are formed upper in the abdomen, right? They are formed at the upper part of the abdomen. But after some times, they're gonna migrate downward, right? So basically, kidneys are formed in the upper abdomen and then they migrate downwards, right? You're welcome. You're welcome, right? So the kidneys are gonna form upwards and then they are gonna move downwards slowly, right? So what is going to happen in case of horseshoe shaped kidneys is that these kidneys, so if this is the one kidney, right, this is the other kidney. So normally we have an artery which is known as the inferior mesenteric artery, right? Normally this artery does not affect, so this is known as the descent of kidneys, right? So a lot of organs in our system during the embryonic development are going to descend, right? So the testes are going to be present in the abdomen and then they are going to descend into the scrotum. Similarly, the kidneys are going to be present in the abdomen and then they are going to move downwards, right? And can be a lot of problems during the downward movements or the descent. For example, whenever the kidneys are moving downwards, they are getting descended. Sometimes the inferior mesenteric artery is going to block these kidneys, right? The inferior mesenteric arteries is going to block these kidneys. They are going to get fused together, right? And then these kidneys are going to look like these. That their inferior poles are going to be merged together, right? Like this. Right. So like this, the inferior poles are going to be merged together. And again, the most important question they could ask you is that first of all, they are going to give you a CT scan of a patient, right? So basically, what are the clinical features? Let's look at the clinical features, right? So mostly the patient is going to be asymptomatic, right? Mostly the patient is going to be asymptomatic, but sometimes the patient could have increased UTIs or increased kidney stones. Right? So there could be increased UTIs and an increased kidney stones. So they could give you a patient that presents with increased amount of UTIs and kidney stones, and then you do an ultrasound, then you do a CT scan, and the CT scan is going to show this. Right now, what is this, and how are we going to see this? Right. So let me show you a CT. Okay, guys, so let's compare these CT scans, right? So first of all, whenever you look at the CT scans, you are going to have to see the sides. So in CT scans, the side are reversed, right? So if you look at this CT scan, the portion which is towards your left hand is going to be the right portion, right? So this is going to be the right portion of the kidney, the right portion of the body, right? And this is going to be the left portion. So the first thing, whenever you look at a CT scan, look at the orientation of the CT scan. What thing is present on the right, what thing is present on the left, and the thing that is present on the right side, and that is the biggest. So right, whenever you look at the biggest thing that is present on the right side, that is going to be your liver. The biggest thing that is going to be present on the right side is going to be liver. And then there is going to be a very small structure that is going to be embedded in the liver. And that structure is going to be known as the gallbladder, right? So this is the gallbladder, this is the liver, right? And the gallbladder is going to be a little bit darker than the rest of the liver, right? So keep this thing in your mind. Now, the next thing that is important is that two main vessels are present in the FCT abdomen. Whenever you look at FCT abdomen, there is going to be two main vessels. What are those vessels? So the vessel that is towards the right side, the vessel that is toward the right side, that is going to be the inferior vena cava, right? Because inferior vena cava is present on the right side and it's present towards the liver, right? So the thing that is present towards the larger body, towards the liver, that is going to be known as the inferior vena cava, and the one that is present on the left side. So this thing is known as the abdominal aorta, right? So whenever you see a CT scan, first orient yourself with the common structures. See where is the inferior vena cava, where is the aorta, where is the vertebral body. So this is the vertebral body, the whitish structure. This is very clear. Now, the last thing that is important is the pancreas, right? So where are the pancreas? So if you look here, this thing which is the leaf-like structure is going to be the pancreas, right? So keep these structures in your mind. Okay. And the last thing which is going to be present towards the vertebral body is going to be the kidney. So this is the one kidney. This is another kidney. Right. And they are both separated from one another. This is a normal CT scan of the abdomen. But then they are going to give you a CT scan like this. And here, this is the liver. Right. This is the gallbladder. This is the inferior vena cava. This is the aorta. And this is one kidney. This is other kidney. But both of these are merged here together. Both of the kidneys are merged together like this at the inferior pole, which is known as the horseshoe shaped kidneys. And then they're going to ask you what is the likely structure that led to the formation of these kidneys. What is the likely structure, or what is the likely blood vessel that led to the formation of this formation? And the most likely structure is going to be the inferior mesenteric artery, right? So the inferior mesenteric artery is going to lead to the formation of these things. Okay. Now the next thing is that there are some syndromes that have increased chances of getting these, right? And what are those syndromes, right? So if you have a trisomy So if you have a trisomy of chromosome 13, 18, 21, right? So if you have any of these trisomies, right, then the horseshoe-shaped kidneys is going to be increased. And the next thing is that horseshoe-shaped kidneys is most commonly present in Turner syndrome. Right? So now, whenever they ask you about Turner syndrome, they are not going to just ask you this, right? They're going to ask the other things as well, right? So whenever you look at horseshoe-shaped kidneys, right, always think so when I told you, I told you about PCT. So whenever you're thinking about PCT, you have to think about a lot of things. So whenever you're thinking about Turner syndrome, what things comes to my mind? So always have like a map of things, right? Always have a network map of things. So right. So draw Turner syndrome in the middle, and then let's think about what things are gonna come from Turner syndrome. First thing that comes into my mind is 45x naught, right? This is the first thing that comes into my mind. Second thing that comes into my mind is short height, right? Third thing that comes into my mind is amenorrhea. Right? Another thing that comes into my mind is infertility. Okay. Cystic hygroma comes into my mind as well. Right. Web neck.
Co- Webbed neck and coarctation as well.
Yes. So quadcation of
Bicep.
aorta. Right. So they can test you on any of these things, right? They could test you any of these things. They could ask you what are the most likely associations of horseshoe shaped kidneys, and then you have to think what are the patients that would have horseshoe shaped kidneys, and then Turner syndrome should come into your mind. Then you should think this, the patient may be having web neck, the patient may have shield chest, the patient may have short stretcher, the patient may have bicuspid aortic valve, right? And what does bicuspid aortic valve leads to? So bicuspid aortic valve is then gonna lead to,
Aortic stenosis.
Peak
yes, so
dissection.
it's gonna
Very
be
early
aortic
aortic
stenosis.
stenosis then.
So there is gonna be early aortic stenosis, right? The patient may have hypertension in early childhood. Why? Because the patient is having quadcation of aorta, right? The patient's FSH and LH would be high. The patient's estrogen would be low, right? So all of these things you should have the mind. You should have in your mind all of these things whenever we are thinking about what do you say, the Turner syndrome, right? Okay. Now let's move forward. So this was a Turner syndrome for you, right? Remember one other thing is that in Turner syndrome, the risk of renal cancer increases. Right? The risk of renal cancer is going to increase in case of Turner syndrome. Okay. After that, we have another thing which is not very important, but let's do it. So that thing is known as the congenital solitary functioning kidney. Right? What is that? It means that the patient is only having one kidney. Right? Majority of the patients with this is going to be asymptomatic. The patient is not going to have any problem. Right? The only problem is going to occur is when both of these kidneys are one when both of the kidneys are going to be absent, right? And when both of the kidneys are going to be absent, you are going to have a lot of problems. And what problems are going to be present? So the problems that you are going to have is that the patient is then going to have porta sequence, right? So this is a thing which is known as a unilateral renal agenesis, right? So what is important is the pathogenesis. What leads to unilateral renal agenesis, right? So basically, remember that unilateral renal agenesis comes from the fact So unilateral urinogenesis comes from the fact that the ureteric bud, remember the pathophysiology, the ureteric bud failed to induce the development of metanephric blastema, right? So it failed to induce the development of metanephric blastema, right? So when ureteric bud fails to induce the differentiation or development of metanephric blastema, then you are gonna get the congenital solitary function kidney, or one kidney is gonna be absent, right? Okay. So when the ureteric bud does not develop, right? So remember, when the ureteric bud does not develop, it won't induce the differentiation of this thing. So then the collecting duct is absent as well, and the PCT and the DCT, all of these things are absent as well. So you're not gonna get any structure, right? Now another thing that is present is the ureteric bud is gonna develop. So that is why those things were important, right? So the ureteric bud developed, but it did not induce to the differentiation of so the ure so the ureteric bud was developing, right? But that ureteric bud did not lead to the formation of what do you know as so so wait a second. So the metanephric blastema was not formed, right? So the ureteric bud was developed, but ureteric bud did not lead to the formation of the metanephric blastema, right? So the metanephric blastema was not formed due to the ureteric bud, right? So this is what is going to happen in case of the multicystic kidney disease, right? So whenever a patient is going to have multicystic dysplastic kidney disease, so what is going to happen is that the collecting system is going to be normal, right? The collecting system is going to be normal. You're going to have a normal collecting system, right? But all of the tubes, right? The PCT, the proximal convoluted tubule, the distal convoluted tubule, right? The loop of Henle, they are not going to form properly, and only cysts of these things are going to be formed, right? Only cysts are going to be present, right? So you have to differentiate between these two things, right? So they could give you a question and they could say that a person comes to you, and when you do an ultrasound, only one kidney is present, and instead of the other kidneys, multiple cysts are present in this patient, right? And then they're going to ask you what is the most likely pathogenesis, or what is the most likely pathophysiology of this condition. So the most likely pathophysiology of this condition is going to be the fact that now they are now maybe they could give you a table, and then maybe they could ask you that the ureteric bud developed or not, right? So now they could say a tick or a absent, right? So obviously the ureteric bud would develop in case of cystic disease, right? But then the thing that would not develop is the metanephric blastema, right? And then they could ask you, was there differentiation of metanephric blastema? So the metanephric blastema would be present, but no differentiation would be present there, right? So did you guess this thing, right? Or any questions regarding these things? Okay. Now we have another thing which is known as the duplex flexing system. Okay, so what is the duplex collecting system? So basically, can anyone tell me where did the collecting system come from? Where did the collecting system was derived from?
The kidneys.
So
Metanephric,
The bud,
Metanephric blastema.
metanephric,
urethric bud, no?
collecting system from the
the,
Mesonephros?
It's a ureteric bud.
yes,
Yeah.
so that
ureteric
Yeah,
was
bud.
you said that.
so
Ureteric bud.
that was the ureteric bud. So please keep this thing in your mind, right? Where does the collecting system come from, and where does the tubules and the glomeruli comes from, right? So the collecting system is gonna come from the ureteric bud. And duplex means that we are having a duplex collecting system. So two collecting systems are present, right? So how can this happen? This is gonna happen because basically instead of one ureteric bud, we had two ureteric buds, right? So instead of one ureteric bud, two. So if this was the metanephric blastema, right? If this was the metanephric blastema and this was the ureteric bud, instead of it entering like this, it's gonna divide here first, right? This thing is gonna divide here first, right? And it's gonna form like this. It's gonna form like this, right? So two parts are gonna form, right? So it's gonna lead to the formation of double system, right? So duplex collecting system is gonna form here, right? This is the thing that is gonna happen in case of duplex collecting system, right? So duplex collecting system is gonna happen because two ureterics bud are gonna reach and they are gonna interact with the metanephric blastema, right? Now, whenever this thing is present, the patient is gonna have a thing which is known as a vesicoureteral reflex, right? Now we are going to do the vesicoureteral reflex in the pathology portion. But remember, whenever a patient is having vesicoureteral reflex, the patient is going to have increased chances of UTIs, right? This is the most common cause of having increased UTIs, right? It is vesicoureteral reflex. It is very strongly associated with vesicoureteral reflex. So now, how could they give you this question? They could say that a 35-year-old or 32-year-old female comes to you and that patient is having burning micturition, dysuria, that is present for a long amount of time, right? So these things are present for a long amount of time, and then this patient all of a sudden now had uh, now you did an ultrasound, and after doing an ultrasound, or instead of ultrasound, you do voiding cyst urethrogram. So this test is known as the VCUG. So you do a voiding cyst urethrogram, and that shows that there is a reflux of urine from the bladder towards the urinary tract. Right. This is known as the vesicoureteral reflux. And then they could ask you what is the most likely pathophysiology of this thing. Because remember, step one is all about pathophysiologies. In step one, they are going to ask you a lot of pathophysiologies. They are going to ask you a lot of these things, right? So what are the different pathophysiologies? How is this condition happening? They want you to diagnose, and after diagnosing, they are going to ask you what pathophysiologies are causing this thing, right? So what would be the pathophysiology? The pathophysiology is that so that ureteric bud would develop. First of all, you're going to ask, did the ureteric bud develop? Yes, the ureteric blood developed. Was there metanephric blastema? Yes, metanephric blastema was present. Was there differentiation of mesonephric blastema? Yes. But then there would be an option that two exureteric buds were present. Right? So instead of one ureteric bud, two ureteric buds were present. That led to the formation of duplex collecting system, and that duplex collecting system then led to vesicoureteral reflex. Right. Now let's do posterior urethral valves. So let's do posterior urethral valves. So what are posterior urethral valves? So again, posterior urethral valves is a very common cause of Potter sequence in male giants. Right? Posterior urethral valves are very common causes of Potter sequence in males. Right. So basically, if we have a urethra, right? So if this is the bladder, so if this is our bladder, so from our bladder we are going to have the final tube, which is known as a urethra, and here from the bladder we are going to have two ureters. Right? This is going to be the right ureter. So this is going to be the left ureter, and this is going to be the right ureter. Both of these are going to enter in the bladder, right at the area of the trigone, and from that a urethra is going to form. So what happens is that sometimes this urethra is going to have a membrane here, right? And this membrane is not going to get degenerated. Membrane is going to be present here, and this membrane is known as the posterior urethral valve. What is going to happen in this condition? The thing that is going to happen in this condition, do you think, so would the bladder be overfilled or would the bladder be underfilled now?
Overfilled.
Yes, so the bladder will be overfilled, right? No urine will be formed, right? So patient would have difficulty voiding, right? And remember, one thing that I always tell my students is that is going to help them a lot is that the body does not like stasis. Right? The nature has created the body in such way that there is no stasis in the body. And if any stasis occurs in the body, there are going to be infections, there are going to be blood clots. So since
Mm.
the bladder is going to be overfilled, there is going to be urinary tract infection here. Right?
Yeah.
Right? So a lot of urinary tract infections are going to happen here, right? Similarly, the patient is going to have failure to thrive and the patient is going to have Potter sequence as well. Why is the patient going to have Potter sequence? Because no urine is going to form here, right? No urine is going to form and the patient is going to have Potter sequence. Now, the USMLEs want you to test on another topic, right? That whether the patient is having whether the patient is having Potter sequence due to posterior urethral valve or ureteropelvic junction obstruction. So how can we differentiate between these two? Anyone?
In the uretropelvic junction, there is hydronephrosis, and in this condition, there is overfilling of the bladder.
Okay, so
In the PUJ, the ureter will be spared. Means there will be no dilatation of the ureters because the obstruction will be at the PUJ level. While in this posterior urethral valve, the both ureters will be dilated as
Good.
much.
Okay. So if we combine both of these answers, right? So both of these answers were right. If we combine both of these answers, we are gonna see that in case of posterior urethral valves, right? In case of posterior urethral valves, let us draw all of the structure within, right? This was the urethra, this was the ureter, and this ureter was going to the kidney, right? This was going to the one kidney, and this was going to another kidney, right? So in case of posterior urethral valve, this is gonna be blocked. So the bladder is gonna be overfilled. The ureters are gonna be overfilled. The kidney is gonna be overfilled as well, right? So we will do a simple ultrasound. We just have to do a bed sound ultrasound. We have to do a POCUS, which is known as a point of care ultrasound, and that ultrasound is gonna show up overfilling of the bladder, overfilling of the ureters, and overfilling of the kidney as well, right? Now, if you look at the pelvic uretero-pelvic junction obstruction, in this case, the so if you look here in this case, if this is the kidney, right, the obstruction is gonna be here, right? So what do you think is gonna happen to the bladder now? What would be the bladder volume?
Will be normal. Uh,
Reduce.
Yes,
Mm.
it would be normal, and the bladder would even shrink, right? It would be
Empty.
shrinked.
Yes.
It would be empty. It would be shrinked, right? It won't be filled. So by just looking at the bladder volume, by just looking at the bladder volume on the ultrasound, we can confirm if the patient is having posterior urethral valves or if the patient is having uh, uretero-pelvic junction obstruction. Right now, the most common cause of renal failure in boys. So remember, one other thing is that posterior urethral valves only occur in boys. Right. Again, posterior urethral valve is an abnormality of males. It's not gonna occur in females. Right? It's only gonna occur in newborn males. It's not gonna occur in females. Second thing is that it's the most common cause of chronic renal insufficiency in men. Okay. So any questions till now, guys? Okay. Now, the next topic that we are going to do is the vesicoureteral reflex. So, what is the vesicoureteral reflex? So, basically, vesicoureteral reflex means that if this is the bladder, right? If this is the bladder, and these are the two ureters, right? So, I hope you are getting these pictures. Okay. So, if this is the bladder, now what is going to happen in that? What is going to happen in that is in this place is that. So, this is a very interesting pathology. Normally, bladders are going to go till here, right? The plot is the ureters are gonna go till here till the bladder. They're gonna go to almost to the end, right? Almost gonna go to the end. And when they go to the end, and whenever you start peeing, whenever you start urinating, your bladder is gonna contract, right? And when the bladder is gonna contract, it's gonna shut this thing, right? This thing is gonna contract, right? So this point is known as a vesicoureteric junction, right? Right. So this is the ureter. The bladder is known as the vesica, right? So a lot of things in medicine are derived from Greek and Latin. So the vesica stands in Latin, it stands for the bladder, right? So this bladder, vesicoureteric junction, gets blocked whenever you start urinating. Why is this thing important? This thing is important because we don't want any urine going back into the ureter, right? We don't want any urine going back into the ureter. If any urine goes back into the ureter, that is a bad news for you because then it's gonna go back into the kidneys, and when goes back into the kidneys, you're gonna have a lot of urination, and the bladder won't be empty, right? So sometimes what is gonna happen is that this this ureter, instead of going so deep, this ureter is just gonna end here, right, at the junction of here, right? And when it ends here, this is known as the short intramural ureter. This is known as the short intramural ureter. And in this case, the ureters won't close during bladder contraction. And when this is known as the vesicoureteral reflex, that whenever you pee, a lot of amount of your urine is gonna go back into the ureter. And when it goes back into the ureter, you are gonna have a lot of UTIs, right? So how is this patient gonna present? They are gonna give you a young patient, and the patient's age is gonna be less than 2 years, and the patient is gonna have a lot of urinary tract infection. So how do urinary tract infection presents in childhood? So they are gonna give you a neonate, and that neonate is gonna be irritable, fever, and listen, right? And then the patient may have some kind of renal injury as well. And then how would you do make the diagnosis? So in order to make that diagnosis, we do a thing which is known as the voiding cyst ureterogram, and that is gonna confirm the diagnosis of vesicoureteral reflux. Right. Most commonly, it happens due to the insufficient insertion of ureter within the vesical valve. Right. So this is how the insertion is going to occur here, right? And then it could happen due to other causes as well. The main thing is that it's going to lead to a lot of recurrent UTIs, right? A lot of recurrent UTIs are going to be formed in these cases, right? So today I was thinking that so you do a lot of question answers with Dr. Maheen as well. I'm going to do some questions with you as well, right? So one or two, maybe two or three questions, and then we're going to discuss those, right? So now this was all the embryology. So any questions regarding the embryology? If not, we are going to move to the anatomy portion. Any anatomy? Okay. So now we are having renal blood flow, right? So I remember I was doing my rotation in the radiology department, right? So I was doing my rotation in the radiology department, and a patient of renal artery stenosis came to us, right? And then the anatomy became very important, right? Because you have to look at every single thing. So first thing is that the first thing that you are gonna notice in the case of renal blood flow is that the renal blood flow goes out with the help of veins, right? So renal blood flow is gonna go out with the help of veins. And what veins do we have in the renal blood flow, right? So we have the left renal vein and the right renal vein, right? We have the left renal vein and the right renal vein. Now the thing that I'm gonna ask you guys is that on which side is the inferior? Oh, sorry. So where is the left? Where are the renal veins gonna empty?
Into the inferior vena cava.
Okay. So if this
No,
is
left
the
into right into the. Okay.
okay, so they are okay. So on which side is the inferior vena cava present?
Right
Right
side.
side.
Right
Right.
side.
Right side. So that is why the right renal vein is gonna go directly into the inferior vena cava. It's gonna go directly into the inferior vena cava, and its course is gonna be very simple, right? So that is why almost all of the things that we have, almost all of the problems of the renal blood flow, they are usually present on the left side. Why? Because the path of left side is very curved, right? So now this is the left renal vein. The left renal vein is gonna receive two additional veins, and that are left suprarenal vein, right? So left suprarenal, which is gonna come from this medulla adrenal glands, and left gonadal vein as well, and then it's gonna go into the inferior vena cava. Okay. Now keep this thing in your mind. Keep this thing in your mind that left renal vein is gonna do a tortuous part. So it's gonna go like this. So the left renal vein is gonna go like this. So almost all of the portions, all the pathologies or the obstruction of the renal veins are gonna occur on the left side. Second thing that is important regarding the renal blood flow is that renal medulla receives very less blood, right? So whenever you are having hypoxia, whenever you are having damages toward the body due to less amount of oxygen, the renal medulla is going to be affected. The renal cortex is not going to be affected. And third thing is that left kidney is most commonly taken during the liver transplant. Why is left kidney most commonly taken during the liver transplant? Can anyone tell me that?
The renal vein is longer.
Because it's
Yes,
longer.
so basically the left renal vein is very much longer on the left side. So I already told you that it covers a bigger path, that it covers a bigger course. That is why the left renal vein is gonna be longer, and that is why this is gonna happen. Okay. Now another thing that is important is renal blood flow is almost 20% of the cardiac output. So 20% of the cardiac output. So normal cardiac output is approximately 6 liters. So 1.2 liters of the body fluid, 6 liters per minute. 1.2 liter of body's blood is gonna go to the renal system, right? It's gonna go to the renal system every time. Now there are a lot of mechanisms of renal blood flow regulation. We are gonna go into the detail of each of these during the physiology portion, right? So basically, If I wanted, I would have a 20-hour or 25-hour lectures just on the regulation of renal blood flow, right? Because how important it is, right? So if I just tell you a basics of renal blood flow, right? So first of all, the Baylis effect, which is the myogenic regulation, it plays a very important role. The prostaglandins play. So Baylis is, so the first thing is that there is a myogenic mechanism, right? So Baylis effect is the myogenic. So I'm not gonna. So don't worry. Um, I'm not telling you all of the things, right? You're gonna cover it in the physiology portion. I'm just telling you that we have a thing which is known as the Baylis effect, right? So the Baylis effect means that the arterioles contract, the afferent and efferent arterioles contract, and when they contract, they are going to control the renal blood flow. They're going to increase or decrease the renal blood flow. Okay, so the why is this thing important? Because a lot of people don't even know how does the renal blood flow mechanisms work. Like if they don't know what is Baylis effect or why is this important, how can they know that how does ACE inhibitors work? How can they know ACE inhibitors work? So basically, ACE inhibitors are gonna work on this Baylis effect, right? They're gonna block. They're gonna dial. They're gonna block the efferent arterioles. That they're gonna block the renal blood flow, and then that is gonna lead to the effect of ACE inhibitors. Similarly, prostaglandins play a very important role in renal blood flow mechanism. Right? When there is increased prostaglandin formation, the renal blood flow is gonna increase. Right? Now, can anyone tell me what drugs reduce the formation of prostaglandins? What are the most important drugs?
NSAIDs inhibit the
And
Yes.
so
Yes, so NSAIDs,
Yes,
right?
yes.
NSAIDs. Now, USMLEs, UWorld and MEMEs, they love to test NSAIDs. They love to test chronic NSAID use. And they are going to give you a question of a patient with chronic lower back pain for the last 20 or 25 years, or they're going to give you a patient of chronic rheumatoid arthritis for the last 20 years, and that patient is taking a lot of NSAIDs. And then they are going to ask you, why is this patient's kidney function not normal, right? And maybe they won't even say that this patient is taking NSAIDs. They're just gonna say that this patient is having back pain for the last 25 years for which he is taking appropriate medications. Now you do a routine checkup and the creatinine level is elevated to 7. And a lot of patients, a lot of students come and they say that I don't get the question. What are they trying to ask me, right? Or I understand that a lot of people, a lot of you go to Reddit as well. A lot of people on Reddit say the exam is very vague, right? Or the USMLEs, they ask you very vague questions. Nothing is vague, right? So they are gonna ask you these things, right? They want you to be clear on these things. So you remember, NSAIDs are gonna block the prostaglandins formation, and the renal blood flow is gonna decrease, right? So now then there is tubuloglomerular mechanism, tubuloglomerular feedback as well. That is gonna act on the distal convoluted tubules, right? So now what drugs do we have for the distal convoluted tubules? We have the thiazide diuretics. That is how they are gonna control the blood pressure, right? Then we have the renin angiotensin system, right? Then we have drugs for this, right? Then we have the ADH system, right? Then we have the ANP and BNP, right? Then we have the parathyroid hormone. So we have a lot of things for these, right? And we are going to discuss all of these things in detail during the physiology lectures. Now, one thing that I want to do today is the ureters, right? So basically, where does the ureters come from? So the ureters are going to come from the renal pelvis, right? So let me show this diagram. So this was the renal pelvis, right? This was the renal pelvis. On from here, the ureter comes. Right? This is the ureter. It's gonna come from the renal pelvis, and the important thing is that it's gonna travel beneath the gonadal arteries, right, and over the iliac arteries, right, and then under the uterine artery. Why are these things important? Why are these functions important? Because USMLEs, you words are gonna give you a patient of ovarian cancer or of uterine cancer or of cervical cancer. All three can come, right? And in all three of these, you are going to explore the pelvis. And when you are going to explore the pelvis, ureter is going to be present there. Why? Because ureters are present near the gonadal vessels, they are present near the uterine vessels, right? They are present near the vas deferens as well. So whenever you are doing any surgeries on the uterine vessels or iliac vessels, right, or the gonadal arteries, ureters can be affected, right? So that is why they are going to ask you these relationships, right? So whenever you do ligation of uterine vessels or ovarian vessels, that can damage the ureter. That can lead to ureteral leak or ureteric obstruction, and then urine is going to form inside your abdomen. That is going to get damaged there, right? Now another thing is that whenever you blow, you do bladder contraction, the ureter is gonna get complex, which is gonna be known as the urine reflex. It's gonna prevent the urine reflex, right? So keep this thing in your mind, right? So this was all the anatomy for you, right? So any questions till now? So anatomy and embryology portion is covered completely. Guys, you can ask me any questions.
Hello, sir.
Yes.
Sir, the time changing have some issues. I have one suggestion. If 1 hour earlier the start, it will be good.
Okay, sure, sure. So we can start. So we can discuss the time in the group, right? So today we can discuss the time in the group, right? And then we can do it as you guys like, right? So believe me, it's been 36 hours since I last slept, right? So I did not sleep the whole night because I had class in the morning today, right? So basically I am moving to US on, I think, 12th of June, right? So I was doing all of my stuff, right? So that is why I could not take the lecture last night in the evening as well. So I came, so I did not sleep because I knew if I would sleep, the lecture would be missed, and I had promised you guys that I would take the lecture, right? I would complete all of these things on time, right? So I was awake, and then yes, so we can discuss the time, right? We can do a poll, we can discuss the time, and we will. I'll try to accommodate the time which is gonna help everyone, right? I will do a time which is gonna help everyone, right? So I'm gonna select a time which is gonna be good for everyone, right? So common time. So 1 hour earlier is completely fine for me, right? So if everyone else agrees it with, we can do it. Okay.
Thank you. Thank you.
You're
Thanks so much.
you're welcome. Now let me pull up one or two questions, right? Let me pull up one or two questions. So okay, so let me show you this. Okay, so see, this is how they're gonna make a question. I just pulled it up. I did not know that this question was present, right? So just look at this question. I'll try to open this, and then this is one. Okay. Okay, so what do you think would be the answer?
We can't see the question.
Oh, you cannot continue
No, we
viewing?
can.
Okay. Okay, so what do you think would be the answer?
We again can't see, sir.
Okay, let me try again. Okay, can you see it now?
Yes, yes.
Okay.
So the question's asking what's going to complement metanephroplastima, which is going to be DCT, which is B.
Yep. Okay. Yes.
Yes.
Agree. Yes, agree. B.
Yes. So again, this was the thing that they're gonna ask you a lot. So the collecting ducts, the minor calyx, the major calyx, and the renal pelvis, right? So all of these things are gonna come from the ureteric bud, right? Now they could ask you another thing as well, right? So they could ask you, where does the Wolffian duct comes from, right? So what does the Wolffian duct gives rise to, right? What does the caudal end of mesonephric duct gives rise to, right? So they can change the questions like this a lot, right? And then they could ask you now another question. Let me show you this. Right? So this is important because this was the thing that I was talking about. Right? Now let me show you this. Let me show you this thing. Okay. So let's look at this question. What do you think would the answer be?
Um, it will be posterior urethral valve
Right?
because there is
Yes.
lateral vesico-ureteric reflux and hydronephrosis.
Yeah, D1,
Posterior urethral
persistence
valve
of
is the
ureteric membrane.
membrane. Yeah.
Yes. So now let's
And
dissect this
also
question.
old boys. So posterior urethral valve will be seen in boys only.
Okay,
That's
so
it.
now let's dissect this question. So the first thing is that let's look at the age. So whenever you are solving a question, whenever you solve a question, the first thing that you're gonna see is the age of the patient, right? First thing is that this is a 1 week old boy, right? This is a 1 week old boy. Why is this thing important? Right? Because a lot of other things that are going to be present, they are not going to present at 1 week of age, right? So vesicoureteral reflex. So what does the option A stands for? What do you think? What does the option A stands for?
This
Anyone?
is
The,
the
it
one with
actually shows vesico-ureteral reflux one.
Okay,
reflux.
so the A option shows us vesicoureteral reflex, right? So basically, whenever I was in the last stages of solving my ULs, right? So whenever I did 30 to 40% of UL, after that, the thing that I started was, instead of just solving the questions, the first thing that I did was to ask myself what is the purpose of this question. Why is this question being asked to me? Like, why are they asking this question? Why? Like, believe me, every question that the world USMLEs or NBMAs ask you, every question that is going to come into your exam, they're not just tricking you, they are not just giving you a question. There is a reason for every question, right? So every question that is getting asked you, there is a very good reason that the question is being asked you, right? There's a very good reason that they're asking you why, what adult derivatives is affected, right? Because if something is affected, the metanephric duct, you're going to have different things, right? So if I apply it to step two concepts, right? If I apply it to the clinical concepts, then the first thing that I'm going to know is that whenever ureteric bud is going to be affected, it means that the Wolffian duct is going to be affected as well, right? The Wolffian duct is going to be affected as well, which means the patient is going to have some kind of male sexual problems as well. So whenever I am looking at some kind of ureteric bud problem, I'm looking at some kind of Wolffian duct problem as well, right? So that is why they are testing me on this thing, right? So now here, the first thing that you're going to look at a question whenever you're solving a question is that why are they asking you this question, right? And if you can answer this question clearly, right? So if you go into the question examiner's mindset, right? So I think of the USMLEs as kind of a sports, right? As some kind of athletics, right? And whenever you look at a good player, especially a good football player or a good soccer player or even a good cricketer, right? If you look at a good cricketer, right? A good cricketer is such a player, right? Who does not only know how to play the ball, right? So if you just know how to play the ball, how to answer the question, you're just a good cricketer, right? But an excellent cricketer or the one who is the best, that person is gonna know where the bowler is gonna goal the ball at, right? Where is the ball gonna come? How fast will be the ball? How much is the ball gonna swing in? How much the goal is gonna swing out? Right? This is cricket, right? Similarly, a good defender is the one who knows how is the attacker gonna attack, right? Is he gonna go to the right? Is he gonna go to the left? Why is he charging at me, right? Why is he moving fast? Why is he moving slow? What is in the mind of the attacker, right? So get in the mindset of the examiner, right? Do not be, do not act like a person who is taking the exam. Whenever you're sitting at the desk, whenever you're sitting at the prometric, right? So this thing is gonna go long. Whenever you're sitting at the prometric, just don't think that you are a student and you are a test taker, right? Go into the examiner's mind, think, why is this question asked me? Why is the examiner asking me this question, right? So basically this is a chess between you and the examiner, right? This is a chess between you and the USMLEs, and the you versus the NBMEs, or you versus the U worlds, right? And if you get overwhelmed by them, it's not good, right? And believe me, the exam is very easy, right? Believe me, it's very easy, it's very solvable, right? If you have the right mindset, if you are prepared the right way, if you know how to solve the questions in the right way, it's going to be very easy. So first thing is that you are going to go into the mindset of the examiner, and below every U world question there is an educational objective. I don't want you to read it, right? I don't want you to read it. I don't want you to read the choices. I don't want you to read the explanation of U world questions, right? They are not going to help you. The thing that is going to help you, you have to predict those, right? When you look at this question, right? When you look at this question, you have to tell me what would be the educational objective of this question, right? Without even looking at the educational objective, right? Instead of just looking at the educational objective, just cramming the educational objective, that is not going to give you any help, right? The help that you are going to get is you have to predict what is the educational objective, right? So just looking at the question, I know what the examiner is, what is going in the examiner's mind, right? I know the examiner is trying to ask me. The examiner wants me to differentiate between the thickened bladder with hydronephrosis versus a bladder which is not thickened and having hydronephrosis. The examiner's only concern at this point is this thing, right? And I already know this thing. When I read the first line, when I read a 1 week old boy and that patient is having urinary problems, the first thing that comes into my mind are two diagnoses, right? So whenever you read the first line, the diagnosis should come into your mind, right? You should have good understanding that what is the demographic population that is coming to you, right? So if a 45-year-old male with sudden onset chest pain is coming to you, what are the three most likely diagnoses? So the first thing is MI, right? The second thing is pulmonary embolism, right? The third thing, maybe because it's 45, maybe the patient is having pneumothorax. Now, when I already know these things from the first line, then what I can do is that after looking at these things, the next thing that I can do is I can look for all the lines of the question. And then I have to only see that which one of these diagnoses were present in the question. Instead of just waiting for the last line, reading all of the cues, reading all of the sentences, and then coming to a diagnosis, what is going to happen in that case is that the examiner is going to confuse you with something. They usually will should throw you some hook, right? So again, just think of USMLEs as some kind of sports, right? If you are a defender, right? So I play soccer. I love soccer, right? So so I play as a central defensive midfielder, and when I was training for my soccer at my school, at my college, my my coach told me one thing, right? So he told me, look at the ball. Do not look at the feet of look at the ball. Do not look at the feet of the player, right? Do not look at the feet of the attacker. Why? Because the attacker is going to do a lot of things with his feet. Yeah, he's going to do a lot of skill moves. He's going to do a lot of things. But remember, the ball is going to stay there. The ball is not going to move when the feet moves, right? He may be doing scissors. He may be doing crossovers. He may be doing step overs, right? He may be fainting. He may be doing a lot of things, right? But in all of those things, the ball is going to stay there, right? And you have to focus on the ball. Similarly, here in USMLEs, they are going to give you some kind of a hook, some kind of a thing with which you're going to get diverted, right? So when you see the first two lines, you should think of something by yourself instead of waiting for the question to feed something in your mind. Because once the question feeds something into your mind, you cannot get rid of that thing. It's very hard to get rid of that notion, right? So with that, there is 1 week boy, and that 1 week boy is having urosepsis, right? So 1 week boy who is having urosepsis, the first thing that comes into my mind is posterior urethral valves, right? The second thing is that comes to my mind is vesicoureteric junction obstruction, right? So these are the pelvico-ureteric junction obstruction, right? So the PUJ obstruction that comes into my mind, right? Now with that thing, with that said, right, I can just look for what is present in the question, right? So the first option stands for vesicoureteral reflex, and I know that vesicoureteral reflex is gonna present not at 1 week. It's gonna present after some days, so like after 4 days or after like 4 months or 5 months, then the patient is gonna have some symptoms, right? So always look at the etiology, always look at the epidemiology of the disease. I know these are not present in first aid, but you can ask me in the group, and I would answer you. What's the epidemiology? In which patient is this thing most commonly present? Crohn's disease is a gastroenterological problem that's more commonly present in the ages of 25 to 35. After that, a patient won't come with Crohn's. Then at the age of 55 to 65, again the patient will come with Crohn's. So keep these deadlines in your, keep these ages in your mind. Right. The next thing is that so A won't be the right answer. Now the next thing that I want you to predict is why A is not the right answer. Right? Why is it A not the right answer? Right? So how can make A the right answer? This is another thing. This is another practice that I want you guys to do. So look at the A option. Right. So congenitally short intravesical uterus. So this was be vesical uterine reflex. So in order to make this right, what other things do I have to do in this patient? Right. So the first thing is that the bladder won't be distant. The bladder won't be distended. Right. So the bladder wall be thickened. So I have to remove bladder wall thickened from the question. That is the first thing. That is the first thing that I have to remove. And then I have to replace 4 week with 5 months. Then maybe the option A would be the right answer. Okay. Then maybe the option A would be the right answer. But here the option A won't be the right answer, right? Now I'm not gonna go into the detail of B, which is a patent urachus. This is the thing that you're gonna do in the reproductive system. So just skip it for now. Right. Now C so now look at the C option, fusion of bilateral metanephros. What do you think this stands for? Fusion of bilateral metanephros.
It's the horseshoe kidney.
Yes, so that is the horseshoe shaped kidney, right? And again, the first thing that should come into my mind is in order to make horseshoe shaped kidney the right diagnosis, first of all, I have to replace 1 week old boy with a 30-year-old woman because that woman may be having Turner and usually it's present in female with Turner syndrome. So first of all, I replace with a 30-year-old woman. The woman won't be having urosepsis. The woman would be asymptomatic and there would be a CT scan that would be showing some kind of anomaly, right? And then the bladder wall won't be diffusely thickened, right? It will only have bilateral hydronephrosis, right? Because it's going to affect the upper urinary tract system, not the lower urinary tract system, right? Again, in case of stenosis at the ureteropelvic junction, the same thing would be present, right? That the bladder won't be distended, right? So when you do these things, when you do these activities, when you differentiate between these things, right? So I don't want you to just cram that when a what is option A, what is option B, what is option C, what are the clinical features of A, what are the clinical features of B, right? Because the patient is not going to come to you and ask you, please doctor, tell me what are the clinical features of Turner syndrome, what is the clinical feature of these things. They want you because they can just chat GPT, they can just go to Google, right? Believe me, when I did my electives in US, when I did my US clinical rotations, US clinical electives, my observerships there, I saw that almost all of the patients that came there, they know literally everything. They literally know what they were having, what was the diagnosis, what was the treatment, right? And USMLEs know this as well, that all of the patients there know these things. They are hiring you for a lot of dollars, right? So doctors are the most highly paid professionals in US. Why are they hiring you for so much when the patients already know the most? They are hiring you because they want you to integrate different things, right? The patients cannot integrate different things. You are there to integrate different things. You are there to differentiate with different things, right? You are there to differentiate between things. So always try to differentiate between different diseases, the different signs, the different symptoms of the diseases. And I believe me, if you can do that, that is going to help you a lot, right? That is going to build you a very strong basis. Okay. So let's keep our session till here today. So what I'm gonna do is that we are gonna do a 2 to 3 or 2 to 4 questions. So you are gonna have Dr. Maheen's session as well, right? And on my own, right? From my own time, I'm gonna do 3 to 4 questions related to the topic that I think are very good. And so these are the UL questions. I have copy and pasted those UL questions here, right? So we are gonna do these, right? Or what you can do, or what we can do is that maybe you can, if you want, if you have doubts regarding any questions, right, that are not cleared in the session, right, you can send me the questions in the group and we can select the questions from there and we can do a session on those questions, on the difficult ones, right? Okay. So take care, guys. This was all from me today, and have a good day. Bye bye.
Hello. Hi. Guys, if we all leave the meeting, then I think we'll get the recording as soon as possible. Dr. Chiaka?